Thank you all for having me. My name is Jennifer Misenhimer. I'm one of the fourth-year general surgery residents at Baylor University Medical Center in Dallas. Today I'll be presenting our research on COVID-19 in our surgical patients. We have no significant disclosures. A little bit about Texas demographics for those of you not familiar. Texas is a state that has a population of roughly 28 million people. The Black and Hispanic population for Texas accounts for less than 60% of our total population. However, during the COVID-19 pandemic, these two patient populations accounted for nearly 66% of our total deaths from COVID-19. When adjusted for age, the number of dying patients from COVID-19 was twice that for Hispanic patients and more than 3.5 times that for Black patients compared to their non-Hispanic white counterparts. Additionally, it's known that these two patient populations have a lower household income compared to their non-Hispanic white counterparts. This is a graphical demonstration of the COVID-19 trends in Dallas. This may be different from anything that you all experienced, but we really didn't see a spike in our COVID numbers until middle of June through August, as opposed to many other places of the country that first saw the initial spike in March of 2020. The purpose of our study was to evaluate how the COVID-19 pandemic affected surgery at our large quaternary referral hospital. We performed a retrospective review of all patients undergoing any surgical procedure, and our variables of interest were patient demographics, payer information, patient outcomes, and surgical case volume and case type. We divided our timeframes of interest into 4 timeframes that were loosely based off of government regulations and lockdown. The pre-COVID timeframe was the beginning of January 2020 through middle of March. Our suspended timeframe was roughly based off of when the Texas governor called for cessation of elective general surgery cases in the middle of March. This roughly lasted about 49 days as our timeframe. The backlog cases at the beginning of May 2020 is when we slowly began reintroducing elective general surgery cases on a case-by-case basis approved by the hospital. This was about 40 days. And the restoration phase from the middle of June through the end of September 2020 was when we were essentially operating at normal levels, and this was 107 days. During this time frame, our large quaternary referral hospital performed 21,424 surgical cases. During the suspended time frame, so during that time frame where all elective general surgery cases has ceased, we had the lowest number of cases, which was not surprising to any of us, at only 2,238 cases. Interestingly, the number of Black and Hispanic populations that underwent surgery during this time frame did increase compared to all other time frames, at 23% and 15% respectively. Medicaid and self-pay patients also increased combined from 10% to 16% during that suspended time frame, and then they remained elevated through the remaining 2 time periods. The restoration phase, where we were essentially operating at normal volume, had the largest number of cases even compared to the pre-pandemic levels, 41% compared to 31%. This graph shows a bi-week distribution of our cases. On the far left-hand side, we have our pre-COVID numbers. Our hospital roughly every week is anywhere from 600 to 700 cases. The second period there is the suspended phase, and you see a sharp decrease in volume of cases with a slow increase in the backlogged case period, which was indeed the shortest time period, and then a remaining increase during the restoration phase, which was the longest time period that we examined. When we examine the sex of the patients undergoing surgery, we see that during the suspended time period, the males actually increased at 54%, and they remained elevated throughout the backlogged and restoration periods. Similarly, the Black and Hispanic patient populations at our hospital were elevated during the suspended time period and remained elevated throughout the remainder of our period of interest. Lastly, when we looked at the payer information, we found that self-pay patients had increased drastically from pre-COVID to suspended time period and remained elevated through the remaining of the 2 time periods. When we looked at the subspecialties of surgical fields at our hospital, we found that there were 4 that remained either constant or increased during our suspended time period. These were trauma, obstetrics, vascular, and thoracic. Having worked on the trauma service, I can attest that there was an initial increase during the suspended time period. And vascular and thoracic are thought to be increased or constant, as they are the two primary subspecialties that deal with ECMO at our large ECMO hospital. In conclusion, COVID-19 disproportionately impacted the number of low-income and minority surgical patients at our large quaternary referral center in Dallas, Texas. Surgical volume has increased compared to pre-pandemic levels and now has even surpassed it. As we embark on the second wave of the pandemic, our hospitals should be cognizant to enact policies to better correct these inequalities with minority patients, as well as work on financial programs to help those facing unemployment. Any questions?